everybody? Welcome to another episode of the Core Consult RX podcast. And if you guys are like, hey, I need to renew my license pretty soon, got good news because we have once again partnered up with PharmConFreeCE.com, and so episode is going to count towards ACPE-Accredited continuing education, as long as you're a member of their platform. So PharmCon basically has set it up so that you can get 1 hour of continuing education, and we're going to try to do this maybe even bi-weekly going forward. So hopefully this is something, if you like it, we can keep ongoing. This is our 7th episode with them, and in order to actually earn the credit, you do have to be a member of their website. The link that you can follow after listening will be in the show notes below, and that will take you to a post-test and evaluation for the activity, and then just make sure you fill out that information, pass the test. There's going to be a password to actually access the test, and that's going to be safety, SAFETY, all caps. And again, that's for free CE members, and it's the CE option through the podcast is available through the unlimited membership benefits. There's no additional cost for that, and so if you're already a member, definitely go check that out and claim the credit. If you're not a free CE member already, then definitely go ahead and check out their library. They have all kinds of different monographs and live CE. They have recorded video lectures where it's more like a lecture style, and obviously Cole and I are also there now. So this will be episode 7 for them, like I said. If you go and you're not a member and you want to sign up, put in the discount code podcast2022 at checkout, and you'll get 15% off the unlimited membership. And then there's also going to be a link in the show notes that'll take you right to that screen as well. So without further ado, Cole, what are we talking about today?
Well, we're talking about a few things. So usually we focus on one, right?
We have 17 things
We have lots of things. No, we're mainly, I guess, the overarching theme is going to be medication safety. And then we're also going to include special populations, and that's medication safety and special populations. We're going to start off with some basics, some metabolism, pharmacology basics, because we want to remind people of some things related to cytochrome P450 and P-glycoprotein. And then we'll hit some other things like pregnancy, bleed risk, kidney function, that sort of thing. So I think it'll be a very lively, interesting one.
Very lively.
Speaking of the CE, though, we just got the emails in South Carolina that our licenses are coming up due. And if I don't set a reminder on my phone, I'm just going to completely forget.
Yeah, I am always in the same boat. I usually wait till April 15th.
So you pay the late fees because you have to pay.
Is it April 1st?
Yeah,
whatever
April 1st.
it is. It's like it's usually a week before it's due, whatever that day is.
Right.
I think I would remember.
Yeah.
But yeah, Cole's right. So if you're in South Carolina listening to us,
oh yeah,
definitely check out Free CE.
Yep.
Because what better way to get free CE or to get CE credit other than listening to
the
us. Soothing voice of me and Cole,
and AJ sometimes.
And AJ when he decides to talk, our executive producer, not just a producer, executive producer, right, AJ?
Big difference.
Big difference. All right, so let's start off, I guess, with the basics.
Yeah.
Metabolism and drug CYP450 metabolism in particular is something that, as a pharmacist, you've had probably more than you ever cared to deal with. But it's good to review. Plus, I believe some of our nursing colleagues may check this out as well, and so maybe they haven't been hit over the head with as much pharmacology as the pharmacists maybe have, and so this is a good review if nothing else. So to kind of we're going to keep it basic with this, but when we think of drug metabolism in particular, we're oftentimes thinking of when it's taken orally, especially when it comes to our drug-drug interactions and whatnot. And so when you swallow a tablet, it gets into the stomach, and then from there it's going to go into the small bowel, and during it's kind of transit through the intestinal tract is where it gets first absorbed into the portal vein to go to the liver, where it's going to be then undergoes this CYP metabolism or various other phase 1 and phase 2 metabolism processes. So there's like glucuronidation and sulfation, all kinds of different things, and so basically that process there is what we're where a lot of our drug-drug interactions happen. Some of it happened in the gut as well as being absorbed. In fact, 3A4, which is a very big drug interaction, is actually primarily in the gut. And so liver and gut are where we're thinking about those reactions, but it's basically those metabolism process and how much of the drug is changed or broken down or made inactive, and how much of it actually reaches systemic circulation is the important thing when it comes to clinical medicine. And so when it comes to a certain dose of a medication, they pick that dose because they know, based on kinetic studies and all that, how much they can kind of expect to get through that first pass metabolism, which is what that's referred to, going through the liver, and then into systemic circulation. So a lot of the hard work has actually been done for us already when it comes to the dosing and things. However, obviously when we put some of these medications together, that's when we can run into a problem.
Right. Put some together, or even have people with altered genetics that might
yes.
We'll get into all that. You were a biochem degree, weren't you?
I was, yes.
See, I was not. So I have bad memories of a lot of the stuff you just talked about we called it pharm chem, but medicinal chemistry, first semester of pharmacy school. It was like one of my first really bad grades since entering college. And yeah, it was a slippery slope after that.
Well, I remember barely talking about CYP interaction. We spent a lot more time with the biochem stuff that we don't ever actually do anything with.
True, yes, true. I don't know what it was, but just the words were just not, like sulfation, glucuronidation, all that stuff was phase 1, phase 2 metabolism. It just was not clicking.
Not clicking.
It was just not clicking.
But look at you now.
Look at me now.
You have a podcast.
Yeah, doesn't mean I know it any better, but yes, just kidding. So we're going to focus on the CYP interactions for a little bit. So the differences in the rate of metabolism of a drug can be due to interactions, like Mike said, genetics, like I said before, and we'll get into all of that. So there's 3 primary things that a drug can be in relation to a cytochrome P450. They can be a substrate for it, they can be an inhibitor for it, or an inhibitor for it, and they can be inducers of a CYP. So we'll get into kind of the specifics of those as well, just so you have a good understanding of that. But induction and inhibition of a CYP can lead to the drug-drug interactions, the adverse effects, increased levels of one drug, decreased levels of a drug, that sort of thing. For example, herbal products, there's various ones out there. St. John's wort is probably the most common culprit, but it can greatly increase the metabolism of many orally administered drugs. So not only prescription medicines, OTC medicines, but herbal supplements you want to be aware of for CYP interactions.
And just as a refresher, when we say substrate, we're talking about, it's basically what the enzyme is actually working on and metabolizing. So if we say that a drug is a substrate of the CYP, it means that it's broken down and metabolized by that CYP.
Yes.
So I don't know, we always got to use fancier words in science, so we call it substrate instead of the thing the enzyme works on.
Target.
But the target, yeah, there you go.
The target.
Thank you, AJ.
What I always think of them as puzzle pieces, and it's like the enzyme is one piece of the puzzle, and it fits nicely with whatever that drug is, and then metabolizes.
That's just like in the textbook, like the picture they show.
That's why I imagine.
Yeah, well, AJ, is it like that in real life?
Yes, actually.
Oh, perfect. Good. Thank you, AJ. He verifies everything for us. He's our fact checker. So when it comes to inducers, they basically, when we're talking about a active drug, so you take the drug, orally, it's already in its active form to do its clinical effect on the body. When you have that, that's a substrate of a certain CYP, or something else that's involved in metabolism, but CYP is primarily what we think of, and you give it with a drug that's an inducer of that same CYP, you're basically increasing the degree of the drug metabolism, the drug that's the substrate. You're increasing how quickly it's broken down. And so if we think about like the serum concentrations of that drug, obviously we would expect them to be lower, because once the drug's at steady state, we don't expect anything to change as far as the metabolism. But if you also speed that metabolism up, it's going to be exiting the system much more quickly. And so, like, just a quick clinical example, obviously, with like something like rifampin, we always know that that's got a lot of drug-drug interactions, but specifically CYP2C9, it's an inducer of that enzyme, whereas warfarin is a substrate of 2C9. So if I'm giving warfarin and I have the therapeutic effect of that, and the INRs between 2 and 3, or wherever my goal might be, and I give this inducer, now all of a sudden it's going to be breaking down that warfarin a lot quicker, and now it's not going to be in the system to actually thin the blood as much as we want, and so the patient could whatever they're being treated for either their clot may not be taken care of, or if they have AFib, they could have a stroke. There's lots of obviously bad outcomes from that. If you ever notice something like metoprolol succinate versus tartrate, where the succinate is the ER, the reason why we have to have like a higher dose that's equivalent a lot of times, especially with Coreg, is actually comes from the manufacturer this way. So metoprolol is depending on which resource you look at, they may say they're 1-1, but that's not quite true. But Coreg, I'll use that as a better example so that I don't get called out. Coreg versus Coreg CR, the reason why we need higher doses of the extended release or the controlled release. So, for example, the 10 milligrams is equivalent to 3.125 twice a day. We need higher doses initially because that first pass metabolism is going to be breaking down and dissolving it. So it's it's going to take longer to get through that first pass metabolism and all that. And so all of a sudden, if we just gave an inducer and it pushes that process further along, now we're going to have a lot more drug kind of leaving the system and getting metabolized quicker, and it's going to throw off our effects of the drug. So
yeah,
2 examples is plenty. Next.
Oh, well, I was going to give one more. Because
please,
thinking of the way that I always remember kind of the inducers and inhibitors and how it works is going back to 9th grade biology term, equilibrium. So on the left side, I think of the enzymes. On the right side, I think of the studied amount of drug. And what we know, if you take this dose in a regular person with the regular amount of activity of CYPs, then it's going to metabolize and excrete at this rate. So if we throw any wrench in the plan, it's going to throw off the equilibrium. So if we induce more CYPs, we're going to have higher CYP activity, which is going to decrease the right side, which would be the drug activity, and vice versa. If we're inhibiting the CYPs, it might increase the drug activity and throw it off its equilibrium. If we have other things that we'll talk about, like kidney or hepatic impairment or genetic issues, it can also throw off that equilibrium. So is 3 examples enough?
Yeah.
I might have just given 4 examples in my 1 example.
It might have been a 2-parter, but that's okay. We'll count it.
I use a semicolon, though.
Got it.
So no periods.
That's good. People taking notes at home, semicolon.
So, speaking of the equilibrium, even amongst maybe a drug interaction, you can have an equilibrium. So you have to be cautious when you're removing drugs, too, that may be inducers or inhibitors, because that can throw off whatever drug level the patient was steady with if they had 2 medications that may have had some sort of drug interaction and they were getting some sort of therapeutic effect from that. If you remove one, then that's going to throw off the equilibrium as well. Along with that, prodrugs. So Mike mentioned drugs being in their active state and metabolized into their active state. So we have something called prodrugs, which is the drug itself is not in its active form. It has to be metabolized or cleaved or whatever in the body to its active form. So one example of that would be codeine. Codeine is inactive until it's converted to its active metabolite, which is morphine, among other metabolites, and that's how it works. So if you if you used an inhibitor, it might decrease the level of the prodrug's active form. So another example could be clopidogrel, which is not active until it is a prodrug and it's not active until it's metabolized as well. So
when we think of Cole kind of hinted at this already, but some of the thinking like the genetic aspect of it, where we talk about polymorphisms. Cole, you didn't actually mention this already, right? Okay, I was looking ahead and I wasn't listening for a second.
I spoiled a couple things, but I didn't actually talk about it.
Okay, so. Good deal. But so genetic polymorphisms, the 2 big ones we kind of think about is the ultra rapid metabolizers, or they're also known as like extensive metabolizers, where the patient, 2D6 is usually a big culprit for this, where the patient's natural activity of 2D6 is a lot more elevated or heightened, I guess you'd say. And so the patient is naturally going to metabolize drugs that are substrates of 2D6 much quicker than a patient who does not have this polymorphism. And that can definitely lead to problems with drug interactions. Cole mentioned, did you say codeine already about the...
I did mention the codeine.
But with the ultra-rapid metabolizer?
No.
Okay, so that's one thing that we know it's a pro-drug, and so it needs to be kind of converted into morphine. But with somebody who's a rapid metabolizer, naturally that process could happen a lot quicker, and they're going to have a lot more morphine in their system than we anticipated. So that's one of the reasons why we don't really like to give this to children usually under 18, because especially under 12 for sure, definitely really under 18 is probably a better, much safer rule of thumb. But that's really because we don't really know if they have that polymorphism or not, and there have been case reports of, newborns and stuff having issues, not even just newborns, but young kids having, respiratory depression and whatnot when given a dose of codeine because their morphine concentration goes up significantly.
Right.
Also, there's poor metabolizers. That's another genetic polymorphism. So, obviously, a poor metabolizer is not going to be breaking down and getting rid of the drug as quick as we think. So, those patients are going to have a much higher instance of toxicity or any sort of adverse effect that could come about from having the drug concentration higher in the serum. And then, the other thing besides those, the genetic polymorphisms, which I am kind of excited about with all the pharmacogenetic advances that we've been making, I think that's going to be a huge part of a lot of different areas of medicine here pretty soon. I know
there's a huge push for
some of you are deep in that space already, but I think that's going to be something that's got a lot of opportunity for pharmacists especially. But besides the genetic component, we also have diet and lifestyle factors that we do got to think about. The one that everybody can quote is the grapefruit juice, which, I used to always joke, like, who the heck drinks grapefruit juice? And then I got called out by a couple of my students, like, oh, hey, I like grapefruit juice. And I'm like, shoot. So for those of you who drink grapefruit juice, obviously we all know that that's an interaction with CYP3A4 that's, seems a little odd, but yes, a drink can definitely cause an issue. And then cigarettes, CYP1A2, also an interaction there. So if somebody is, starts smoking randomly for some reason, or usually it's the case of them stopping, they stop smoking, that's when that CYP interaction could potentially be an issue. And so, there's lots of things to consider. I will say that at the same time, I don't want drug-drug interactions to seem like, oh, this is the scariest thing ever. If you see anything that pops up as an interaction, that's it, cut it off. I mean, one of the things, obviously, as pharmacists that we do all the time is hit that override button.
Yeah.
Because we know whether it's clinically relevant or not, or what things to kind of monitor for and make sure that the patient's still getting the therapeutic response and lack of adverse effects that we're hoping for. So
I think it's important to review because a lot of us have CYP fatigue. I mean, override fatigue easily, but then we also will see like, this interacts with moderate inhibitors of CYP3A4, and we're like, okay, well, override or whatever. But you can make a decision, especially if you're initiating a drug or making a recommendation about whether it's clinically relevant. And if you're looking up an interaction checker like Lexicomp, it's going to spit out a letter, a C, D, whatever, as far as how significant it thinks the drug interaction is. If you click into it, you can read some additional information as well that they'll pull from the labels, and sometimes, it's a C or a D, but they give recommendations about adjusted dosing or different dosing intervals or whatever. And so you can look into it a little deeper and maybe come up with good recommendations.
And they also will tell you more information about where that actual rating came from. And usually it's not all the drugs in that class. It's usually a couple of them that have been studied.
Yep.
And so like with macrolides and things like that, that's a really important concept too, is not just because it comes up as an interaction. It's being kind of pinging that off the class. It's not necessarily the data's, doesn't necessarily support that particular drug necessarily being an interaction.
And so the interaction checker, it all comes from, this is so weird once you understand like background, it all comes from the package insert. So if you go into the package insert and scroll down, you can find a long list of classes, specific drugs, whatever, that they have had to put into the package insert to get it approved. And I mean, I won't say all because I don't know exactly how they do their algorithms, but the majority of what you're looking at when you run those interaction checks is it's just running it against the knowledge that it has about its FDA label and then spitting out that information for you to read conveniently right there. It's also not all inclusive, because the FDA approval may not have all the information that might come out after approval and that sort of thing. So
yep.
I definitely have run interaction checks on things that I was sure interact and it didn't pop up. So yeah. Anyways.
Or I had this one interaction in my head the whole time, and then I actually read the data that Lexicomp has on where that came from, and I'll go, oh, that's not that important.
Right.
So
yeah, sometimes it looks scary, but if you look into it and use some clinical decision making, it's not that scary.
Yeah. So the other big kind of drug interaction that we like to think about is the P-glycoprotein. So the metabolism part of it is one thing, but really P-glycoprotein is more interested in the absorption side of kinetics, and so it's basically the drug that as it's moving through the small intestine and moving towards being excreted in the feces, the P-glycoprotein is the pump that, as the drug is absorbed, that P-glycoprotein catches some of that and brings it right back out of, that first pass metabolism path and spits it right back into the intestines to push it towards the end of the GI system and turn it into feces. And so that process of how much of the drug is actually reabsorbed or re-excreted, I should say, from P-glycoprotein is important, because some actual drugs are inhibitors or inducers of that particular pump. And so it's the same concept as you have an inhibitor of that, you're going to have more drug in central circulation because less of it is being dumped out of that first pass metabolism back into the GI tract. And then if it's an inducer, you're going to have more that's put back into the small intestine. And so that's going to have less systemic circulation available. And so it is important to kind of consider that as well. P-glycoprotein is a separate area, but it's still just as important when it comes to drug-drug interactions.
Yeah, and conceptually, I think it's important to understand the difference between metabolism and excretion, because we've all heard the ADME acronym, absorption, distribution, metabolism, excretion. So we've gone into a lot of detail on metabolism, and then we just touched on excretion a little bit. But they happen in two different areas. And so sometimes they can kind of seem like they overlap as far as just getting rid of the drug. That's right. You understand that it gets rid of the active drug. But metabolism, the way I like to think about it, is it's not really getting rid of it as far as it leaving your body. It's just taking what's already there and breaking it down into an inactive form. The excretion is actually pumping maybe active drug out of your body or out of a place where it could be effective and then out of your body. So it's a little bit different.
Yeah. A lot of times it's just making the drug more water soluble, getting ready for the kidneys to turn it into urine.
Yep.
Or put it into urine. But that's a good point. Well done, Cole. Well said.
Thank you. I'm all about the analogies today.
Yeah, that's good. Good stuff. A lot of energy.
Yeah.
So that's, some basic metabolism stuff. Obviously, definitely encourage you guys to kind of look into that deeper if you're not super familiar with it or if you haven't thought about it in a long time. But let's get into some kind of patient populations that safety is an important aspect of, especially when it comes to selecting pharmacotherapy options. And the number one thing I think that I always think about and worry about really is patients who are pregnant.
Yes.
Because I never want to make a mistake with anything or any recommendation that I've given or that I've started on somebody, but pregnant patients, I am always like triple check things because I'm terrified of doing something
if
wrong
I
in that
ever
area.
Got a question like, I'm pregnant, is this okay in pregnancy? I would say, even if I was very confident, I would say yes, but hold, I'm going to look it up, because I would always double check before I let them leave.
It's probably a good policy. Unless you're an OB, that's probably a good policy. Yes. And even then, double check yourself. So the number one thing to kind of, one of the most important things, I should say, I don't know if there's a rating system in place, but one of the most important
Number
things
33, most important,
is medications that have a teratogenic effect, or teratogens, which is basically just any agent that can potentially halt a pregnancy or cause any sort of like fetal malformations. And so, teratogenic drugs obviously need to be discontinued immediately if a patient finds out that they're pregnant, or in an ideal situation, we want to kind of stop those ahead of time if we know that the patient is actively, trying to conceive. And so there's plenty of other medications that we could possibly switch to depending on what drug that the patient's on, but we really got to keep that in mind because they can be potentially very harmful to the fetus. So some, drugs that we, in some cases, have to kind of, use in very, very special cases that we still know can cause some harm. Those situations are out there, and it's really going to be between obviously the OB, the mother, and anybody else involved with her care, because obviously we don't want any negative outcomes with the mother, but we also want to protect the fetus as well. And so there's cases like the one I always think of is Lamotrigine. Lamotrigine during pregnancy definitely carries some congenital risks. However, seizures can also cause issues. So if a patient is tried other medications and whatnot, and this was a not planned pregnancy, and it's kind of like you're already in the middle of, the prenatal care, you got to make that choice of, okay, do we try another agent, and they potentially start having seizures again? There's, that's a discussion that I think everyone has to kind of make for themselves, but explaining the risks to the mother, I think, is a very important piece. And make sure that they are a very active part of the decision-making process, and that's not just us using our clinical judgment in this regard.
Yeah, seizures and pregnancy are a difficult.
Yeah,
it's a difficult thing to treat, I should say. Yes. So there are some kind of key drugs that we think of and should be red flags to you anytime you think that a patient might be pregnant or is at risk of becoming pregnant if you see them. So the big one that everybody thinks of is with acne, Isotretinoin, because it has an iPledge program, a REMS program, because of its teratogenic risk, but also for acne, the topical retinoids like tazarotene is teratogenic as well. Some others that you might consider, like one to consider to have the old category X for pregnancy, or now we just say do not use in pregnancy, would be fluoroquinolones, so do not use those in pregnancy. Other ones to consider would be tetracyclines, and also metronidazole, but specifically it's contraindicated in the first trimester. Some others that are heavy hitters would be statins, which are very common drugs. A lot of these cardiovascular-related drugs are very common. Statins, ACE inhibitors, ARBs, also aliskiren, and then Entresto, sacubitril, valsartan, atenolol as well. All of those have teratogenic effects. And then hormones you want to be cautious with or avoid, like estradiol and progesterone as well.
And then just some other kind of miscellaneous medications, lithium, methotrexate, topiramate, divalproex, hydroxyurea, paroxetine we can throw in there. Lots of drugs that do have other alternatives that we could probably switch the mother to, but things just to kind of be, and there's obviously a lot more than that, but definitely things to kind of keep in mind. And if you're ever not sure, just make sure that you pull up Lexicomp or some other drug information resource. And I know I can speak to Lexicomp because that's the one I use a lot, but Lexicomp will have like a whole pregnancy discussion now, which is part of the package insert changes from the old rating scale to this, and we've talked about this in one of our other previous podcasts, but that will give you more information than you could ever hope for. And so just make sure that you kind of read through that if there's any question or you're wanting to know more information about.
And that's one thing that makes it difficult, because you have the whole discussion in front of you. Of course, the patient wants to know yes or no, is this safe in pregnancy? And it's like, well, I think I should give you all this information and let you make this decision as to whether you feel comfortable with it. I can give you my, I guess, opinion, but yeah, it feels like with the rating system, it was a little more cut and dry, but that might have been the problem, is that it was a little more cut and dry because there's nuance even within the quote unquote categories that they used to have. So yeah, that's drugs to avoid. But other issues we have in pregnancy, which last time we talked about pregnancy, I think my wife was pregnant. So I remember talking about this stuff and thinking like I was dealing with it firsthand,
Yeah.
So one is nausea and vomiting, very common in pregnancy, especially in the first trimester. So one drug that would be considered first line by the American College of Obstetrics and Gynecology is pyridoxine. So which is vitamin B6, which is either by itself or in combination with doxylamine. So they come together in combo as a brand name called Diclegis, which I believe has kind of come down in price some, but it was traditionally pretty expensive, especially because vitamin B6 and doxylamine are both over-the-counter drugs in different doses than come in Diclegis, but they could be combined to create that and be a more cost-effective option for patients, and tends to work pretty well, and it's safe. Another one that would be considered second line behind this would be metoclopramide, Reglan. It has the potential for extrapyramidal side effects, specifically tardive dyskinesia, which we talked about previously on the podcast. So that's why it would be considered more of a second line option. Probably the most common one that gets thrown around, especially in non-pregnant patients, is Zofran, ondansetron. But there are some potential concerns with it. There was a large case control study that found an increased risk of oral clefts with ondansetron, though recent studies have not shown an increase in congenital anomalies. So do with that what you will.
Yeah. Hypertension and pregnancy. There's definitely a different treatment algorithm when it comes to pregnancy in treating hypertension. And so we'll kind of go through some of the meds, and then I'll give you some new data that just came out January 2022, hot off the press or so. Kind of like we're a couple weeks late, so it's not super new at this point, but it's all right.
I think a couple weeks is pretty good.
No, it needs to be the day before or nothing. No,
we'll just tell everybody we're recording this the day the day before it came out.
Right. That's good call, Cole.
We just didn't release it for a few weeks.
Right. It's exactly what we did.
Yep.
I don't even know why I brought it up.
Don't even know.
I'm embarrassed. So, hypertension and pregnancy basically defined as systolic blood pressure above 140 or diastolic above 90. And then, that's based on 2 or more measurements, and we typically will give it some time in between those, sometimes even hours apart if possible, if the patient has time for all that. But, there's also obviously the weight code hypertension and nerves that can go into having an appointment at the OB office and, thinking about a new child and all that stuff like that. So we do want to get a couple measurements to make sure that at least we're seeing the blood pressure accurately. So there's some important like lifestyle changes, to consider, the salt reduction and everything like that, but also the exercise, even if it's something, 50 minutes of walking 30 days a week or so, that can reduce the incidence of hypertension threefold over women who are more sedentary. So something, basically taking a walk can keep you from having to deal with hypertension during the pregnancy. But as far as like stress reduction or activity restriction, and how that improves pregnancy outcomes, there hasn't really been any good solid evidence that truly shows that helps. I mean, now in some situations where there's other things going on, other comorbidities, that may be different. But prolonged bed rest is actually along with activity restriction and stress reduction in patients who are just dealing with hypertension, not talking about other aspects of pregnancy that could go wrong. So I'm going to make sure I make that clear. But bed rest and things like that can actually increase the risk of complications in some women, if especially in regards to just hypertension by itself.
Related to blood pressure.
Yeah.
I remember being concerned when my wife was pregnant, like, can she continue, asking the OB if she could continue doing exercise or if it could possibly be harmful. And I remember her telling us that the womb is like a fortress, and so the baby was very safe continuing to do whatever regular exercises that she did, as long as she wasn't like doing up downs or whatever.
Yeah.
Which is like, football, you jump and smack your stomach against the ground and then do a push-up and jump back up.
Well, she's usually doing like lineman type drills, right?
Right, yeah, bear crawls and all that
I
good
could
stuff.
see it.
Yeah.
She seems like the type that's really into those type of workouts.
Her type of workout. Not really. So following up on that, there's some preferred agents to use in hypertension, and then some in pregnancy, and then some to avoid, of course. So labetalol is increasingly being considered kind of the go-to, or at least used over methyl-dopa because it has fewer side effects. So definitely considered a first-line agent. A couple others that would be considered preferred would be methyl-dopa, like I mentioned. Long-term follow-up data supports its safety. It just has some more side effects. And then nifedipine, more of a long-acting agent and definitely preferred. Other things that may be safe, something else would be thiazides. Definitely not a first-line agent, but it's probably safe at lower doses if it started prior to conception, if you're using it for essential hypertension, but not really a first-line agent. And then, of course, you want to avoid ACEs, ARBs, and direct renin inhibitors. They're contraindicated. Major teratogenicity, fetal toxicity, and potential death. So do not use those, and make sure to stop them if a patient is thinking about becoming or becomes pregnant.
And the new data I was referring to that came out in January of 2022 was a meta-analysis that basically was looking at oral antihypertensives for non-severe pregnancy hypertension. And so they compared labetalol, other beta blockers, methyl-dopa, calcium channel blockers, and then like mixed or multi-drug therapy options versus placebo or each other. And so what they found is that basically just definitely check out the study if you have the time. But the conclusion, I'm just reading off the abstract here, but in summary, the all commonly prescribed antihypertensives in pregnancy reduce the risk of severe hypertension, but labetalol may also decrease proteinuria as well as preeclampsia and fetal newborn death. And so the evidence is lacking from any other safety outcomes. And so the study, or the meta-analysis, included 61 studies that were informative. 72 actually were identified all in all, and there was only 6,923 patients included, even though there was 61 studies. So it shows you how hard it is to actually have a high patient population in these studies, which is very understandable. But labetalol has some new and decent data that has come out now. So
Yeah.
something, at least another win for labetalol.
It's not bad.
But I definitely you'll see methyl-dopa still utilized a lot too.
Yeah. Okay, so another common issue for pregnant patients is coughs, cold, allergy type symptoms. So first line drugs are actually kind of what you wouldn't consider first line otherwise, and those could be diphenhydramine and chlorpheniramine, pretty sedating antihistamines. Loratadine and cetirizine can be used, but more during the second and third trimesters of pregnancy. And if a nasal steroid is needed, budesonide and beclomethasone are going to be the safest ones. For pain, acetaminophen is generally considered the safe thing. There is an FDA investigation going on right now looking into a possible link between acetaminophen use in pregnancy and ADHD or autism in children. So if I'm interested to see the results, of course, just the fact they're studying doesn't necessarily mean anything, but I'm interested to see what they come up with about that.
Yeah, and I will say too, like with the antihistamines, like typically those are initially the second, third trimesters, like when they utilize those, but I feel like now, like a lot of OBs will still recommend those in the first.
Yeah, I was gonna say I didn't want to recommend against what I was reading, but I'm pretty sure Anna used the loratadine.
I think at this point we will use those in first line as well.
Yeah.
And then also just to kind of throw out there with the budesonide being like the recommended nasal steroid, that's because the studies are kind of centered around that. It's not that fluticasone has been shown to have any harm or anything like that. I think it's just the safety studies have been surrounding budesonide and beclomethasone. So I think it's one of those things that it's more so just like playing it safe because you have data to support it.
Yeah, I think she used Flonase too.
Yeah,
not saying we should do what we did, but I'm pretty sure she used Flonase too.
Yeah, you gotta remember.
And it was just because they were selling them in packs of 6 at Costco. What are you supposed to do?
You need to quit being so cheap.
What are you supposed to do?
This is ridiculous. Oh, guys, you got to work on Cole's frugal lifestyle. So just throw that out there just to say that it's not, if you're pregnant and you're taking Flonase, don't think we're spitting nonsense. That's the data is just a lot surrounded on budesonide.
Yeah.
Anyways, okay, so dealing with things like VTE, patients oftentimes will be put on low molecular weight heparin or unfractionated heparin. DOACs do not at this point have like solid safety data to where they've actually switched their recommendations. I think there are some ongoing studies and things that people are looking at, and hopefully we'll know definitively here in the near future whether we can use those as well. But typically enoxaparin or one of those is the go-to. Hypothyroidism, levothyroxine is still the main medication that's utilized in pregnancy. However, when we think about the actual dose, patients will oftentimes need a much higher dose during pregnancy. So it can go the necessary dose to keep their thyroid levels normalized is 30 to 50% higher than it was before pregnancy. So that's something to kind of keep in mind if you have a patient who's on those type of medications. Make sure that they have bumped up and they're monitoring the levels appropriately. But if hypothyroidism is not treated during pregnancy, it can definitely increase the risk of a miscarriage and other issues. So definitely something to be monitoring and making sure that their blood work is being monitored.
All these newer drugs like DOACs that just don't have any data. Like a lot of the drugs I work with are new too, and they just don't have any data, so we have to recommend against them. So I guess they're just never going to have data, or will they eventually do animal studies, or do they just kind of leave it like no data, we're just never going to look at it? Kind of
I feel like the DOACs have some data that's come out, and then I have to double check myself for sure, but I'm pretty sure they've had some, and I'm.
And is it just like people who are worth risking it, and so they just do it and do case studies, or could it be like people who didn't know they were pregnant and they happen to be on it for a period of time or through their first trimester or something? I'm interested to know where this data ends up coming in aftermarket,
Yeah, I feel like it's probably, high risk that is without the medication that have
risk outweighs benefit thing.
Yeah, something like that, or
or benefit outweighs risk, I should say.
Yeah, because I feel like if it's just more so like retrospective, it'd be a lot harder to use that data to actually justify the recommendations and stuff. But
Right.
I don't know. I'm also answering.
I feel like we could get some animal studies here. You know
Yeah.
what I'm saying?
I also
Give me something.
I like how I just start answering questions that I don't really know the answer to. I'm just what I feel is that it's probably based on my extensive knowledge of clinical studies.
We're just presuming.
Yeah, so I don't know. I have to look into that, but that's I definitely think that I am pretty sure that DOAC studies are being looked at.
Okay, so hyperthyroidism. So Mike talked about hypo. In general, mild cases may not need to be treated. It's, if possible, normalize the mother's thyroid function prior to pregnancy. If drug treatment is necessary in instances like Graves' disease, propylthiouracil and methimazole are the two drugs to use, but at specific times during the pregnancy. PTU is preferred during the first trimester, and then methimazole is preferred during the second and third trimesters. And of course, always use reputable sources when checking for interactions and medication use in pregnant women. There's a variety of them. Briggs Drugs in Pregnancy and Lactation is one. There's also a LactMed app, LactMed, which is it put out by the NIH? Or is that just where you find it?
It's definitely where the link to it, but I'd have to look for.
Well,
sure.
It seems pretty trustworthy to me. I used it all the time. It's for breastfeeding, but I used it all the time.
Yeah.
American Academy of Pediatrics has recommendations, and American College of Obstetrics and Gynecologists as well.
Yeah, definitely check your resources. Don't use your Core Consult podcast for your sole resource when it comes to pregnancy.
Use the really good stuff.
But all right, so. That's some highlights. If you want more information on different things we've covered for patients who are pregnant, make sure you check out that. We have a whole podcast episode on that, so check that out. Let's talk about patients who are at a increased risk for having a bleed, because I think it's something that we run into a lot. Patients that are on DOACs or warfarin or whatever, enoxaparin, things we have to kind of consider and think about when it comes to they're already at a bleed risk, obviously, anytime they're on a blood thinner. And then when you talk about anything else that could increase that risk, we want to avoid if possible. So the obvious thing like anti-platelet drugs. Now, there are situations where a patient may be on an anti-platelet medication or aspirin and an anti-platelet medication, like if they've just had a cabbage or a stent placed, and then they also have AFib, and they have a high stroke risk because of that, and so they are on anticoagulation as well. I have seen patients that are on all three before. It's a little shocking to see it, and the bleed risk is very high, but in some cases they may be on all three. So if you do see that, just get some more information. Don't assume it's craziness coming from the cardiologist. But Nsaids and Ssris are another kind of thing to consider. Not necessarily a huge risk, depending on what the patient's actually taking as far as the anticoagulation or therapy, but NSAIDs basically are going to help or decrease the platelet aggregation and could potentially increase the bleed risk slightly. SSRIs, same kind of thing. If we think about like platelets in general, they have this dense granule that stores multiple things that are involved with signaling during platelet aggregation. So, they store ATP, they store free calcium, and they also store serotonin. They also have like the alpha granule that has like von Willebrand factor and fibrinogen and some other things, platelet factor 4, all that good stuff. But the dense granule does not have a way of actually producing or making its own serotonin. So it actually has to take that from the environment and store it in the dense granule. So as your serotonin levels are available, that brings that in, stores it, and then it's ready to be used whenever it needs to. When you have a patient who's on an SSRI and you have basically blocked the presynaptic reabsorption or reuptake of serotonin, that activity actually plays a role at the dense granule as well and keeps the serotonin from being able to be transported inside the dense granule. So it's one of those things that when we're thinking about, just in general, SSRIs and bleed risk and all that, it's usually very low risk. But if a patient is already on multiple medications that could cause it, it'd be something to at least think about.
Right.
And be aware of. It's not usually clinically relevant, but it is something to consider. Same with NSAIDs. You just got to be careful, outweigh see if the risk outweighs the benefit or vice versa, and just make sure that at least the patient's aware and watching for signs of and symptoms of bleeding. Herbal supplements are always the one that I think of as a big risk, and it's not just like the drug-drug interactions, but it could also just be like decreasing in platelet aggregation and other aspects of the clotting process. But some of the herbals to remember, the big kind of category I think of is the G's. So ginger, garlic, ginkgo, ginseng, those type of things.
Grapefruit juice.
Yeah.
No.
Wait, I was going to say, wait, that's not right. Anyways, thanks, Cole. Just totally threw me off. Yeah, but so the G's, and then also turmeric, fenugreek, evening primrose. There's some other common herbal supplements, especially when it comes to fenugreek and evening primrose and things like that can be, involved with lactation and things like that. And so sometimes if a patient is on taking those along with some sort of anticoagulation or whatever their therapy they're on, that can increase the bleed risk as well. So at least something to consider and warn patients about.
Yeah, especially because it's not usually reported and pop up on the EMR to do an interaction check and whatnot.
Yep.
So that was bleed risk. So there's also with AFib, we have to calculate a stroke risk, and this helps us decide whether we're going to anticoagulate a patient who has AFib. So there's a score that we talked about on the podcast before called the CHADS-VASc score, or the CHADS-2 VASc score, or the CHAD-2 VASc score. Yeah, it used to be different, but it's not anymore. So each letter is an acronym that stands for something that's going to assign an amount of points, and with a score greater than 2, greater than or equal to 2 in men, or greater than or equal to 3 in women, this would recommend anticoagulation. So the C is congestive heart failure, the H is hypertension, blood pressure over 140, over 90. I wonder if that'll ever be updated. Or change.
One. Yeah.
I don't, probably not, but it's interesting. Age 75 years or older gets 2 points. Diabetes, stroke or TIA gets 2 points. Vascular disease, age of 65 to 74 gets 1 point. And then sex category is the S, and female gets an automatic point.
Yeah, and that's obviously sex given at birth, not always double check that as well. Obviously, if you have a patient that is, trans or something like that, you do want to make sure that it's the sex assigned at birth is what this is referring to. I don't know if I'm assuming.
Is that why they put the clunky name in there of sex category instead of? I'm trying to think of another way they could have done it to where it could have been a less clunky name for it.
I don't know. I actually wanted to go back and look and see if they've reworded that. I could see that somebody getting irritated by that. Yeah. But anyways.
As far as we know, it's still CHADS-VASc.
Yeah. Yep. Remember when it used to be just the CHAD score?
Yes, it used to just
That's what I learned in school.
And were there any 2s in there too, or was there always 2s?
I think the 2s was for stroke. Was still because it was like CHADS and the 2 after the S.
Yeah.
But
and 2 after the initial A.
Maybe I don't remember. See, I don't remember that one.
That's right. It was always the CHADS-2 VASc if they had to say it the whole thing.
Yeah,
so that's why I was like CHAD-2 VASc.
I don't know. I had to go. I was just mad that halfway through my pharmacy school
they added
career,
5 extra letters you had to learn.
They're like, hey, remember what you guys learned? Don't worry about that anymore.
Yeah. Well, worry about that plus 4 extra letters.
So, all right. Atrial fibrillation, obviously, this is where this comes in, like Cole was saying. But just to kind of recap with, we've talked about this in other studies, or other episodes, rather, but a lot of the studies that have come out have basically justified using the DOACs instead of warfarin to alleviate that risk. And that's pretty much the name of the game, is just trying to find as many ways possible to keep that risk as low as possible. We do not want our patients bleeding out. That's not ideal.
Right. And kind of going along with that, you can calculate a HAS-Bled score, which is another acronym. I won't go through the whole thing. I'll just give you some tidbits about it. But it doesn't necessarily give you a specific number that says right here, your HAS-Bled score is too high to anticoagulate. It's more just a guide to show you patients who may be at increased risk. So hypertension, abnormal renal or liver function, stroke, bleeding, labile INRs, elderly age, and then drugs or alcohol. All of those can give points, 1 or 2. To increase your HAS-Bled score up to 9. And in general, so like a HAS-Bled score of 1, for instance, about 1, just barely over 1 patient per 100 patients, so about 1% of patients may have a bleed, and then at a HAS-Bled score of 5, that goes all the way up to 12.5 patients per 100. So it kind of increases, especially when you hit the HAS-BLED score of 3, it really starts to increase pretty significantly to their bleed risk.
All right. So, we've covered pregnancy, covered patients who are at a bleed risk.
Yep. Metabolism and excretion.
Yep. Let's talk real quick about some drug-induced kidney damage potentially, or kidney injuries. So we've always, when we think about like an acute kidney injury or drug-induced kidney injury, the surface level, we kind of lump all that together, but there's actually several different kind of subcategories of that. So they have like tubular epithelial cell damage. That can be a result of certain medications, like the aminoglycosides are usually in that group, or amphotericin B, cyclosporin, some of those type of meds can be tenofovir is another one, the old version, especially the disoprosyl fumarate. But that's more on the tubular injury or necrosis. There's also some osmotic nephropathy that can happen with like drugs like mannitol or dextran, IV immunoglobulin. And then when we think about the hemodynamically mediated kidney injury, I feel like that's the one that we typically think about when it comes to like primary care type stuff. That's where your ACEs, ARBs, your SGLT2 inhibitors, your NSAIDs, that's where that risk could potentially come into play. And so since there's so many different kind of ways we could take this and we only have a limited amount of time, I did think one of the important things to bring up was ACEs and ARBs and like instance of an acute kidney injury after starting one. So one of the things that we've kind of, we've mentioned this on their podcast and whatnot, but just in case you're new to us, the ACEs and ARBs, are nephroprotective. And so that's something that we have kind of drilled into our heads as far as that. But then it also sounds very counterintuitive to, hey, we got to monitor for a kidney injury after starting one of these agents. And so it's something that it basically has to do with the intraglomerular pressure as far as the dilation of the afferent and efferent arterioles. We won't get into some of the patho and stuff right now, but you can basically decrease some of that that pressure, and it can lower the kidney's ability to kind of filter, and the eGFR goes down and serum creatinine usually goes up. It's not always just directly from the ACE or ARB. That can be kind of a precipitating, I guess, thing that's added to the mix, but usually it's also accompanied by dehydration and other issues. And we do expect a patient's serum creatinine to kind of be increased from baseline whenever they start a ACE or ARB. We would expect it to go 15, maybe even 20%, but 30% or higher from the patient's baseline. And I think that's an important kind of differentiating like fact that I know we've mentioned before, but just to kind of hit home, even if the patient's serum creatinine is pretty elevated at baseline, it's 30% up increased serum creatinine from their baseline, not a set baseline or anything like that. So if you have a patient with chronic kidney disease, does not mean that they're not a candidate for an ACE or ARB. In fact, we want them to be on an ACE or ARB ideally. And so there's a study from New England Journal of Medicine back in 2006, I believe, and it doesn't have a cool name, unfortunately, but it's the efficacy and safety of Banazapril for advanced chronic renal insufficiency. And what they were doing is basically taking Banazapril versus placebo in these patients who had, really end stage, or at least stage 4 in some categories, kidney disease. And so if you look at like the baseline, they had one group that's the baseline serum creatinine was as high as 5, which is quite up there. And so what they basically saw was that the outcome they were looking for was the creatinine doubling the end-stage renal disease or death was the primary composite. And when you compare the Banazapril to placebo, Banazapril decreased significantly the risk of that primary outcome, and then the number needed to treat was only 5 in those patients. So definitely a valuable asset to have on board. In fact, if we have a patient who has an AKI with an ACE or ARB, a lot of times we end up giving hydration and then re-challenging the ACE or ARB if possible, because we do know that they can be nephroprotective and all that good stuff long
Yep.
term. So just wanted to reiterate that if something you haven't thought about in a while, because I think that's an important thing to kind of keep in mind.
I agree.
But yeah, so I think the other big one we had, it's because there's other, tubular interstitial disease and chronic interstitial nephritis and all kinds of other things. They can kind of be some patho behind the drug-induced renal disease or an AKI or whatnot. But I think the other kind of big one is Nsaids. Cole, do you want to check on that? Or you want to jump on it?
Yeah. So I'll do my best to try to explain this. Help me out if I start to fail. But so Nsaids can initiate an AKI, and it's kind of related to COX-2 or cyclooxygenase. So Nsaids inhibit cyclooxygenase catalyzed synthesis of vasodilatory prostaglandins, including prostaglandins I2, which is prostacyclin, you may have heard of, and E2 from arachidonic acid. And we talked about this before on the podcast previously as well. But the prostaglandins are synthesized in the renal cortex and the medulla by vascular endothelial and glomerular mesangial cells. Their effects are primarily local, but they result in a net afferent arteriolar vasodilation, right? So similar to kind of what we were talking about, a little bit different actually than what we were talking about with the ACEs and Rs, but talking about the afferent arteriole, a net vasodilation. So the vasodilatory prostaglandins have limited activity in states of normal renal blood flow, but in states of decreased renal blood flow, their synthesis is increased, and they serve a pretty vital autoregulatory role in the protection against renal ischemia, hypoxia, because they antagonize the renal arteriolar vasoconstriction from angiotensin II, norepinephrine, and vasopressin, those three. So you give an NSAID in the setting of reduced renal blood flow, it'll blunt the usual compensatory increase in prostaglandin activity. This alters the normal autoregulatory balance in favor of renal vasoconstrictors, thereby promoting renal ischemia and reduction in glomerular filtration, causing the acute kidney injury. Did you follow that?
That was a mouthful.
That was a mouthful. Did I pronounce everything correctly?
I think so.
I thought I did.
So and this is a study that doesn't have a ton to do with this, but I do want to just mention a couple points from it. The Precision study was looking at basically cardiovascular safety of celecoxib, naproxen, and ibuprofen for patients with arthritis. And one of the things that they were looking for, the cardiovascular safety as the primary outcome, but one of the other things they reported was the adverse effects for serious GI events and renal events. And when you compare the different classes to each other, specifically naproxen and the celecoxib was the one that I spent the most time kind of looking at, because I always thought of those as being two that could potentially decrease the risk of cardiovascular disease compared to other NSAIDs. But what they found is that the renal events were actually the same in both groups. There was not a statistical difference. So it's one of those things that we don't have to worry as much, or at least we don't use the COX-2 inhibitor specifically thinking that you're going to negate those renal risks. It's in that same group of concerns there that we would have. So just make sure that you kind of keep that in mind. Naproxen, celecoxib, any of those, if the patient already has renal disease and is dehydrated a lot, something we would want to be careful with.
Right.
All right, so the last thing we'll kind of talk about is some drug-induced liver disease or liver injuries. There's various types of this as well. The two that we'll touch on is the autoimmune injuries. It is basically antibody-mediated cytotoxicity or direct cellular toxicity, basically. And this can happen from a couple different ways, involving the autoimmune sort of path, but there's like antibody-mediated cytotoxicity, like I said, and a lot of the common drugs that we would think about with that would be sulfamethoxazole, carbamazepine, some fluoroquinolones, and then also the TNF-alpha inhibitors. And then we also have some drugs that can basically cause a type of autoimmune injury, specifically to the liver, called the chronic active hepatitis. And some of the culprits for that would be dantrolene, isoniazid, phenytoin, nitrofurantoin, trazodone, and methyl-dopa. It's, again, not super common or anything like that, but it can happen, and those are the drugs associated with it. If you have a suspicion of chronic kind of active chronic active hepatitis, usually the patient's like symptoms get severe, like the hepatitis symptoms get severe, and then they go away and they come back again. It's just kind of like a cyclical pattern. Also, patients will a lot of times have anti-nuclear antibodies, or ANA, which is one of the things we look for in autoimmune disorders. And so if you run rheumatoid labs on a patient that's positive, that might be indicative of the chronic active hepatitis, if their other symptoms match. The other thing about this specific subcategory is that the diagnosis can be pretty difficult, because a lot of times you basically have to let the person have or at least in their history have long or multiple episodes because of the long exposure to certain medications. So the good thing is we don't have to worry about this a lot, because most of these drugs are not going to be used long term. Phenytoin is one that exception, and methyl dope is an exception, but one of those things that hopefully we just can use some better drugs if possible anyway, especially with unless you're pregnant with methyl dope is not really utilized in hypertension nearly as much as some of the other agents. So
right.
Just something to think about. And then there's also idiosyncratic drug-related hepatotoxicity, which can be rare, but it's oftentimes it's basically like an allergic reaction to the drug, and that reaction, hypersensitivity reaction, leads to the hepatotoxicity. So a lot of times, if there is an allergic component, you'll have elevated eosinophils and granulomas, and then also fever, rash, things like that. And it's usually kind of a dose-related situation, and a lot of times patients will be on the medication for less than a month when they have it. Sometimes it's days. So there's just some to mention: minocycline, nitrofurantoin, phenytoin again, augmentin, Bactrim, ACEs, and then allopurinol. And a lot of these are basically due to changes in the human leukocyte antigen, or HLA, phenotypes, and that can really put a patient at risk depending on any changes, like getting different or mutations that specific alleles that can put a patient's susceptibility, and how severe the reaction is in the liver to that particular drug. So allopurinol is the one that I always think about. That if you look at some of the pre-treatment things to do, if you can do the HLA allele genotype testing, that's actually something they say would be ideal, but it never actually gets done in most cases. But it's a very, very rare thing, but it can happen. And there's also the non-allergic component too that can cause hepatotoxicity, that is idiosyncratic, and amiodarone, isoniazid, and ketoconazole are the three big ones to think about there. But yeah. So there's just a few. There's also more, things to consider with hepatotoxicity as well, just like with nephro, but just some kind of things to worry about. If you have a patient who you're worried about severe, hepatodysfunction or cirrhosis and all that, then make sure you calculate a child's P score. There's all kinds of good apps. I think we talked about one on our Hepatitis C podcast episode we did on the HepCalc app that you can get for a few bucks. That's got all the different kind of calculations that are available for various hepato disease states. But so kind of keep that in mind, because a lot of drugs will have some issues with that depending on the patient's liver function. If they're ever considering whether or not there's a potential for drug-induced liver injury with the medication or supplement or herbal supplement that you're about to use, Liver Tox is a very good source of information, and that's definitely one I would recommend checking out. One of the things I hear a lot about, like toxicities, metformin, and people think in my page, I don't know why this is like so commonly talked about. This one time I used this app is to double check myself, because I kept having so many patients bring up that, oh man, so and so told me it's bad for my liver. And at first I was like, no, it's not. And then I heard it from so many people that I was like, I need to look this and see where this is coming from. But it's it's extremely rare to even have any kind of elevated liver enzymes from that. And in fact, sometimes they go down with metformin. So
I've heard that on multiple occasions too. I wonder where that comes from.
I'm wondering if it has to do with like fenformin when that was on the market.
But did it have issues with the liver? I thought it was with the
lactic acidosis, but I'm wondering if that's partly where it is, or if people are just...
what we need to do? We need to call 1-800-BAD-DRUG and we need to see what they're telling people. You seen those commercials and stuff? Oh, it's like
1-800-BAD-DRUG.
Yeah, well, that's just a joking example, but there'll be a commercial about like metformin in a class action lawsuit because of some sort of thing. It's always like, call 1-800-BAD-DRUG, and
we should do that
to get in with your class action lawsuit. So we need to figure out what they're telling people, because that's probably, that's got to be where this stuff's coming from, right?
I would imagine.
Yeah.
Either that or the person's neighbor who just needed any excuse not to take metformin.
It's the same neighbor that's telling everybody.
Maybe. Everyone's got the neighbor that's an expert on drug therapy.
Yeah.
But, anything else we got for this, Cole?
I feel like we just did 5 episodes in one.
Did we? Yeah, we kind of did.
Yeah.
I wasn't keeping track of time, so I'm pretty sure we're over. But
no, it's fine.
We'll wrap it up now. So you guys, thanks for sticking with us. I appreciate it. Make sure if you've, once you've obviously signed up for freece.com, make sure you go take that post podcast test and all that good stuff, and get your credit, renew your license so you can keep working. That's patients need you, so make sure you get that done. Let us know if you have any feedback or anything we can do better for these continuing ed type episodes. And we definitely want you guys to feel like you're getting something out of them and utilizing this relatively new platform for continuing education. So, appreciate you guys listening. Thanks for taking the time. Let us know if you have any questions or concerns. Our emails will be in the show notes, or any of the social media platforms you can get in touch with us. And, we will catch you guys in the next episode. Have a great night.